This is Nasim Miller reporting from the annual meeting of the American Society of Clinical Oncology in Chicago. A major theme this year is precision medicine. ASCO President Dr. Michael Link explains.
So precision medicine really is the development of the right drug to the right patient. So how do we determine that? First, we need to understand the patient's tumor. We understand that cancer is really a heterogeneous collection of diseases. If one looks at childhood leukemia, it's really perhaps 17 or 20 different diseases, each looking the same under the microscope, but they're different molecular drivers of the leukemia. So we have to develop therapies that are specific for that child's leukemia based on the molecular profile. Similarly, we have to look at the host, the patient himself or herself, who metabolizes drugs differently, is susceptible to different toxicities, and ultimately the idea of precision medicine is to take into account both the specifics of the patient's cancer and the specifics of the patient's own genome, as we call it, what toxicities they're susceptible to and what they're not susceptible to, and design therapies specifically precisely defined for that patient. That's the future. What we're seeing at this meeting, of course, is the beginnings of that with drugs that are very effective when you target them to a patient's tumor according to what the target of that patient's tumor is.
Dr. Link also spoke about trial design of the future, which is specified in an ASCO blueprint.
Well, one of the key findings is that sometimes these drugs will be effective only for a very small subset of patients. So in lung cancer, one of the best examples is crizotinib, which was developed and approved last summer. It's effective for only 5% of patients with lung cancer, but it will only be effective for that 5% that has the ALK mutation that's targeted by crizotinib. So if you tried this drug on everybody with lung cancer, only 5% of the patients would respond, and you probably wouldn't have recognized how effective it is. But by understanding that this drug will only work for that subset, the response rate of 70% or almost 80% was seen in that trial, and that's quite dramatic. But it doesn't work for patients who don't have the target. So that's exactly the kind of the future of cancer therapy. Well, we need to select those patients that are appropriate for the drug, and then we are likely to see very, very positive responses, as we've seen in melanoma when we choose the patients correctly for a BRAF inhibitor, when we select patients with lung cancer who have the ALK mutation. And ironically, there's other tumors that also have this ALK mutation where the drug works equally or even better. For example, in non-Hodgkin's lymphoma, a specific subtype that has the ALK mutation, the drug is practically a miracle drug in terms of how effective it is. And it also works in a subset of children with neuroblastoma who have this same mutation. So if you triage the patients according to what molecular abnormality is, you're likely to see better responses, and that's the kind of trial design that we're going to need in the future, and that's what we specify in the blueprint. An additional problem that needs to be overcome is when we want to try to use two targeted agents in the same patient. But if the two targeted agents come from two different companies, we have a number of what should be surmountable problems in terms of intellectual property that have to be overcome in order to conduct those trials. We think that those are achievable, overcomable, and should allow the future to be very bright for treatment of cancers and development of new therapies.
Dr. Link also addressed the cost issue related to paying for multiple drugs.
This is an unsustainable model that we have, and so we're going to have more reasonable approaches. And one of our approaches that ASCO is taking is to look at those things that are non-beneficial and look at those things that we can change in our behavior so that we don't prescribe therapies that don't work as a way of cost savings to counteract the very expensive drugs that we know are effective and we'd like to make certain that our patients can get.